Hi, my name is Dr. Tiffany Lu. I am a general internal medicine physician and addiction medicine specialist based in the Bronx, New York. In this mini video, I will be focusing on opioid use disorder treatment during pregnancy and using a case-based approach to discuss buprenorphine initiation, stabilization, and maintenance specific to the pregnant and peripartum patient. Let's dive in. Miss X is a 34-year-old woman who presents to your hospital's labor and delivery triage requesting help with opioid detox. Her estimated gestational age is 32 weeks based on a dating ultrasound done in a prior emergency department visit, but she has not had any prenatal care otherwise. She reports that she cut down from using about 10 bags to 4 to 5 bags a day of heroin and fentanyl intranasally per day during this pregnancy. She also smokes about a quarter pack of cigarettes and does not use other substances. She last used about 4 hours ago and starting to feel anxious from mild opioid withdrawal. And she also shares that she is a single mother to 2 younger children who are currently staying with her mother while she came to the hospital. She's separated from the father of her children. She's housed and not employed. Let's unpack that. Miss X's untreated opioid use disorder with active opioid withdrawal, as well as lack of prenatal care engagement, reminds us to contextualize her in the larger landscape of opioid use disorder in pregnancy. This is a high-risk period that should prompt addiction clinicians to collaborate with the labor and delivery team, because 1 in 6 pregnancy-associated deaths are related to drug overdose, which has increased by over 80% between 2017 to 2020. And most of these drug-related overdose deaths involve fentanyl and synthetic opioids. On the other hand, maternal opioid-related diagnoses at delivery has increased by 131% between 2010 to 2017. And opioid use disorder among pregnant individuals is associated with a 6-fold higher risk for all-cause mortality compared to those without an OUD diagnosis. Instead of focusing on Miss X's lack of prenatal care engagement, we need to pivot to the current needs that she has. After all, pregnancy is a motivating time for change. But there are major barriers for seeking prenatal care for patients with opioid use disorder, including stigma, discrimination, and fear of criminalization, lack of knowledgeable clinicians, and misinformation about neonatal opioid withdrawal syndrome. And this quote really highlights the kind of sentiment that our patients may hold when they come and set their foot in the door in the hospital or clinic. Quote, "I found out that I was pregnant in the middle of a relapse, and I thought that I could not keep the baby. I also felt shame, and I was mortified and trying to get prenatal or drug treatment help. I knew they would judge me. They would also judge me if I lost a pregnancy. There was no way out, and the thought of walking into a hospital and saying I'm using was terrifying." So, acknowledging the kind of barriers in place and the high-risk period that this is, pregnancy is a critical time to offer treatment, namely medications for opioid use disorder. Medically supervised withdrawal, or in this patient's request for opioid detox, is not advised. This is associated with high relapse rates of up to 90% and poor outcomes, and highlighted in ACOG Expert Opinion 2017. Initiation of medication for opioid use disorder and prenatal care tends to occur together in the same trimester, which is highlighting that prenatal care and medications for opioid use disorder can be synergistically provided in a patient's care. And adherence to medication for opioid use disorder throughout pregnancy, even if it's the latter half of pregnancy, is associated with better postpartum outcomes and not necessarily even accessing additional support services. There are benefits for medications in treating opioid use disorder during pregnancy that we know for the mother as well as the fetus. On the maternal side, 70% reduction in overdose-related deaths, as well as decrease in the risk of acquisition and transmission of HIV, Hep B, and Hep C are important to know about. And on the fetal side, reducing fluctuations in maternal opioid levels and thereby reducing fetal stress can be beneficial, along with decrease in intrauterine fetal demise rates, intrauteral growth restriction rates, and decrease in preterm delivery risk. And overall, not conferring increases in the risk of congenital abnormalities. Now let's come back to Miss X. Knowing about the benefits of medications for opioid use disorder, especially during pregnancy, Miss X shares that she started using opioids about 4 years ago, first with non-prescribed oxycodone in a setting of back pain, and then continued on to intranasal heroin and fentanyl use. She's had 2 prior attempts to seek opioid use disorder care during pregnancy, first through the medical ED at 16 weeks, then through a local inpatient detox unit at 28 weeks. Both times she was referred out to outpatient care and then another hospital, respectively. This led her to try buprenorphine on her own, but she felt worse after taking a 2 milligram initial dose. She feels like this is why she needs to start methadone instead for opioid withdrawal. Let's look at the evidence for how we determine between buprenorphine versus methadone in a pregnant person. The most well-known data comes from the MOTHER trial, which is a double-blinded, randomized control trial of 175 pregnant patients with opioid use disorder who were randomized to methadone versus buprenorphine between 2005 and 2008. The trial found that buprenorphine was associated with improved outcomes for neonatal abstinence syndrome, including lower doses of morphine administered, shorter duration of neonatal abstinence syndrome, and shorter hospital stay for infants. The caveat here is that no significant differences in other neonatal or maternal outcomes were found, and there was a higher rate of treatment dropout for women who were randomized to taking buprenorphine versus those to methadone. In real-world data, we have an observational study of over 15,000 persons who received buprenorphine or methadone during pregnancy between 2010 to 2018. The authors found that there were lower rates of adverse neonatal outcomes associated with buprenorphine compared to methadone. And this covered lower rates of neonatal abstinence syndrome, preterm birth, smaller for gestational age, as well as low birth weight incidence. And the caveat here from the observational study is that there were no significant differences in maternal outcomes. How do we translate this data into practice? We need to acknowledge the importance of shared decision-making when we're selecting buprenorphine versus methadone as medication treatment for opioid use disorder. And the commentary led by Tiago et al. I want to highlight here. Rarely do we find that pregnant patients have not had prior positive or negative experiences with either buprenorphine or methadone. They usually know what the best treatment is for them. Findings from studies are valuable data to share with patients. Still, the ultimate treatment decision must be the result of shared decision-making, rather than promoting one medication over another. As we're talking about buprenorphine versus methadone, we also need to talk about real concerns for buprenorphine initiation during pregnancy. There are fentanyl-related concerns, which apply to the pregnant individual as well as outside of pregnancy, which is the onset of opioid withdrawal can be unpredictable and prolonged. The chronic use of fentanyl leads to redistribution in the fat tissue and slow clearance. And people with opioid use disorder increasingly avoid buprenorphine due to the fear or experience of precipitated withdrawal. There are also pregnancy-related concerns where we may not want to tolerate maternal and fetal distress if prolonged or precipitated withdrawal. To respond to the fentanyl era and pregnancy-related concerns for buprenorphine initiation, I want to highlight an emerging method for buprenorphine initiation during pregnancy, which is low-dose buprenorphine initiation with opioid continuation. And what is this? This is when buprenorphine, instead of starting at traditional doses of 2 to 8 milligrams per dose, we're starting at very low doses of less than 2 milligrams and increasing gradually while continuing and overlapping with a full opioid agonist. I must note that evidence here is limited to case reports and retrospective cohorts. There are no randomized controlled trial data published yet. This is previously known as microdosing, but is not the recommended term, and more information can be found on the ASAM clinical guidance document on buprenorphine. Why do low-dose initiation? This is a great method for patients who might be intolerant of developing opioid withdrawal or have prior experience of precipitated withdrawal. They might be regularly using street opioids with fentanyl, on chronic opioids for chronic pain, or looking to transition from methadone to buprenorphine. In our case of using this during pregnancy, the benefit would be to potentially minimize maternal and fetal distress from anticipated or precipitated opioid withdrawal. There are guiding principles to use for low-dose buprenorphine initiation during pregnancy. First, we need to choose an appropriate clinical setting. A patient may need to actually be admitted to the inpatient setting to optimize fetal monitoring and maternal comfort if their estimated gestational age is in advance of 24 weeks. We need to initiate buprenorphine at a low dose, titrate this up gradually. And in the hospital setting, we can continue the full opioid agonist, including administering methadone. We can offer adjunctive medications for symptomatic relief. We can definitely pause or delay the buprenorphine dosing titration if withdrawal occurs. And we have the duty to communicate frequently with the patient and between care team members. I want to show you some example protocols for low-dose buprenorphine initiation. Here is an example of a 4-day protocol where buprenorphine is started buccally and increased to sublingual dosing such that by day 4, the patient has gone from approximately 2 milligrams of buprenorphine to start all the way to 24 and even 32 milligrams of sublingual buprenorphine. During the first 3 days of the protocol, methadone, and in this example, 50 milligrams, is being utilized as an opioid to stabilize initial opioid withdrawal. Another example, which takes a little longer here, is shown. This is an example 7-day inpatient protocol where buprenorphine is started buccally and up-titrated more gradually from about 0.3 milligrams, then to about 24 to 32 milligrams by the final day of the protocol, again utilizing methadone as a full opioid agonist. It's important to acknowledge that you need to adapt a protocol that works for your clinic, your hospital, as well as the patient. Now let's go back to Ms. X. With shared decision-making and review of the risks and benefits of initiating methadone versus buprenorphine for opioid withdrawal in pregnancy, she actually elects for low-dose buprenorphine initiation with opioid continuation. Methadone was started at 50 milligrams and increased up to 60 milligrams on day 1 to stabilize her acute opioid withdrawal, accounting for altered metabolism of methadone during pregnancy. And at the same time, buprenorphine was gradually increased according to the low-dose initiation protocol. She was successfully transitioned to buprenorphine naloxone sublingually 8 milligrams 3 times a day by day 4. Now Ms. X wants to know what to expect for opioid use disorder and prenatal care as she gets ready to be discharged. It's important now that we pause and talk about buprenorphine stabilization in pregnancy. Plasma concentrations of sublingual buprenorphine may be lower during pregnancy versus before or after pregnancy. This is because buprenorphine metabolism can be altered due to physiologic changes during pregnancy, and patients may perceive that change in their plasma concentrations via having clinically significant withdrawal symptoms or cravings even when they have been previously on a stable dose. So the takeaway here is that buprenorphine dose may need to be increased or split dose throughout pregnancy, which can be revisited and adjusted postpartum. Another concern about buprenorphine stabilization in pregnancy is whether or not extended-release subcutaneous buprenorphine formulations can be used safely. We have case studies highlighting that it can be used safely and with good clinical effect during pregnancy. Existing formulations may be considered in real-world settings based on a risk and benefit discussion. There are ongoing clinical trials to examine safety, efficacy, and pharmacokinetics, so we'll stay tuned for that. Looking ahead beyond buprenorphine stabilization, we need to plan for retention in the peripartum period. I want to break this down into 3 main clinical domains. The first is to help educate the patient that during the time of delivery, especially if the patient has significant peripartum pain, that pain management is something that we can do while the patient is on buprenorphine. We can do this by maintaining the daily dose of the medication. We can utilize multimodal analgesia, and we can split dose the medication. Next, we need to counsel the patient on the risk for neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. This is expected and treatable and not necessarily dose dependent. And the rooming in, skin to skin, breastfeeding are all different strategies that can be really helpful to help the neonate cope through this period. Finally, we need to educate on breastfeeding. In fact, a lot of patients might be worried that they can't safely breastfeed while taking buprenorphine or methadone in the postpartum period, and we want to encourage this, especially if they're taking a medication for OUD treatment and not actively using non-prescribed substances. The elephant in the room is that patients are often concerned about legal risks. Our job as clinicians is to reassure our patient that taking medication for opioid use disorder is not in and of itself a reason to report to Child Protective Services. It is important to know your legal context because state laws vary. In several states, substance use during pregnancy may be considered child abuse or neglect, and that healthcare professionals may be required to test and report suspected prenatal substance use. Some states do not mandate reporting for suspected or confirmed substance use unless there is reasonable cause to suspect child neglect or abuse. So what do we do with that? You definitely need to know your state laws, and no matter what, it's important to focus on safety. Taking the medication for opioid use disorder helps reduce perinatal opioid use and promote better maternal and neonatal outcomes. Practically, as we're planning for discharge, we really need to think of this as the need for dual planning for both opioid use disorder and peripartum care. Let's, again, affirm the patient's decision to seek care. Then we need to arrange close follow-up and warm handoffs, and this might be between addiction medicine, obstetrics and gynecology, maternal and fetal medicine, and pediatrics. We need to minimize gaps in medication treatment, and this means sublingual buprenorphine prescriptions can be sent to a hospital pharmacy or nearby pharmacy to ensure a meds-to-bed delivery system, hopefully with the patient leaving with medications in hand. Consider prescribing up to 30 days of medication supply to bridge the patient to the outpatient follow-up appointment instead of having to run in and out of their home to go to the pharmacy to pick it up. And we can utilize telephonic check-ins and televisits in between to promote medication adherence. Facilitating care coordination is important, and this can start with confirming the patient has a working phone number updated in the medical chart and safety planning around emergency contacts. And finally, it's important to discuss harm reduction and supports both for opioid use disorder as well as peripartum care, including providing naloxone and overdose prevention tools and tips, and linking the patient with peer recovery coaching, navigator, or community health worker services. Now let's come back to Miss X. She agrees to increase her sublingual buprenorphine dose and split it into 16 milligrams in the morning, 8 milligrams in the afternoon, and 8 milligrams in the evening. Her discharge medication supply was arranged for bedside delivery from the hospital-based outpatient pharmacy, and her appointments were arranged in the OB and addiction clinics on the same day for next week, and she's looking forward to following up. And the takeaway from her case shows us that pregnancy is a window of opportunity to engage individuals in care, starting with initiating medication for opioid use disorder. And both buprenorphine and methadone can be safe in pregnancy, although buprenorphine has been found to be associated with fewer adverse neonatal outcomes. Low-dose buprenorphine initiation with opioid continuation is an emerging approach for pregnant persons in the fentanyl era. Buprenorphine dose stabilization during pregnancy may require increased dose and frequency of sublingual buprenorphine, and we can consider injectable buprenorphine. Anticipating concerns and optimizing buprenorphine treatment retention is critical as we work together to improve perinatal outcomes. Thank you.